Welcome to the podcast, Braxton. I am super excited to finally meet you face to face, virtually. And I appreciate you deciding to come on and give us a little insight into what you do, how you support NOS, because you are part of our team, and some of the incredible work you're doing around crisis intervention, which is a pretty broad term in a sense. So you're going to give us a little bit of an insight to like the niche that you focus in. So I'm going to turn it over to you. Go ahead and introduce yourself. Tell me a little bit about your work, just a general overview, and then we'll kind of jump in from there.
Thanks, Casey. I really appreciate the opportunity to be here. I'm excited to promote and bring awareness to crisis intervention. My name's Braxton Morrison. I have a PhD in human services with a specialization in crisis intervention. My background is in emergency services. I was in the Army from 2012 to 2014, medically discharged for chronic pain and PTSD. So when I'm talking today, I'm presenting from multiple different aspects, living with experience of mental health challenges, living with providing that crisis intervention to emergency services, and then being on the end of an emergency services worker who didn't get that crisis intervention or as a veteran. So when I got out of the military, I joined emergency medical services right away as an EMT, worked my way up to be a paramedic. And in that time, I also became a police officer. I did both for roughly 8 years, and then just completely stopped everything last November, just due to time commitments and mental health challenges and just a bunch of other things that weren't fitting that lifestyle for me anymore and my journey to being as well as I possibly can. I do still do death investigator, so I respond to any death in our county and investigate that. So keeping kind of my foot in the door with emergency services, kind of a different topic, but they're the least recognized profession of emergency services. So part of my crisis intervention journey is really bringing awareness to that profession as well. In 2017 was when I started my crisis intervention work with emergency services, very unofficial, kind of here and there throughout a few years till 2020, when I co-founded our local critical incident stress management team. We provide immediate crisis intervention to emergency services personnel directly after they may experience a traumatic event. And so I still do that. Founded a suicide prevention coalition last year, and then I serve on the board of NOS, as you said, as a treasurer and vice president. Just started doing those this year.
You have so much in your corner, and it's fantastic. It's definitely a tale to what you experienced and kind of how that brought you here. I want to backtrack a little bit to that, particularly what moments or memories, experiences do you have that stand out between when you came out of the Army and to this point that kind of were turning points, right, for you into delving into crisis intervention?
Sure. Yeah, I didn't have any coming out of the Army. I really had no idea what I was doing with my life as a 21, 22-year-old, as most 21 and 22-year-olds probably don't. And immediately after getting out of the Army, I knew from the beginning that I wanted to be a police officer. Back in 2014 timeframe, the stigma surrounding being in law enforcement and having mental health challenges was still very high. It is still very high, but I think that it has gotten better over the years. And so basically what that looked like is getting VA disability. I got out and I didn't want it to affect me at all in a career choice. So I told them that I didn't want any kind of help. And I didn't do anything with my PTSD from 2014 to 2021. I didn't have any kind of treatment, any kind of help. I did nothing with it. So in 2021 was my aha moment, if you will. I honestly don't remember what I was doing. I think some yard work. And I just was reflecting on the last 7 years. And I had been learning quite a bit about crisis intervention and traumatic stress over the years, especially since starting crisis intervention work. And all of the training and experience and knowledge and symptomology that I was having just clicked for me in that moment. And I was like, wow, I probably need to get some help. And so I did. So I've started on what I would call my journey to Wellness, I don't know that I think you can call it recovery, but I think that's difficult because while we want to have expectancy, which is a core principle of crisis intervention, we want to expect that people will get better. Sometimes getting better isn't necessarily being treated, which is what a lot of people like to say. And trauma doesn't always get treated. Trauma can sometimes be managed or mitigated or alleviated. So I hope someday that I can be treated, and I expect my symptomology to be mitigated. But my practitioner said it well, and more so that it can go into remission. So hopefully you're not dealing with that symptomology every day.
So is it something that you still experience in your day to day that kind of either maybe one day it impacts, what you're doing minorly and another day it might be a little bit more major? Does it just kind of depend on how you're managing it day to day?
Yeah, so I don't remember who told me this analogy, but you think about trauma as going into a grocery store, and think about the healthy fruits and vegetables and protein and everything in one shelf, and then across the aisle you have all of the junk food, the chips, the cookies, all of the things that we shouldn't be eating, right? And then imagine imagine the junk food as your depression, your anxiety, your trauma, PTSD, all of the mental health challenges that people experience. And then imagine the other side as happiness, wellness, just being able to live well. If you walked into the grocery store and knew that you were going to be choosing depression, anxiety, trauma, would you walk over and choose those as your things to pick to eat? Or would you go over and choose happiness and wellness and positive mental health? So to long-windedly answer your question, trauma is something that I personally experience every day in some way, shape, or form. A lot of the time I don't know that I'm even experiencing because I've adapted my life to it. But symptomology of traumatic stress is so broad because it affects all three parts of the brain. So you have a low brain, a midbrain, and a high brain. And trauma affects all of those. So if we look at the symptomology of PTSD, for example, it has symptoms of depression. It has symptoms of anxiety. It has symptoms of ADHD. It has symptoms, even a little bit bipolar, because one day you can wake up and having the best day, and I don't know if tomorrow is going to be the same or if I'll be in a completely different mood. So it's really hard to say what you do and do not experience every day, or what you will or will not experience every day, because sometimes you just don't know.
So kind of going back to your professional work,
Mm-hmm.
can you kind of tell me a little bit more about your responsibilities and how what you're doing contributes to the human services field as a whole?
Sure. Yeah, so I actually had no idea what the overall field of human services was until starting in my PhD program and continuing through that, and then even into this year and joining National Organization for Human Services. I actually was going to be going into a public policy and administration PhD. Thank goodness I didn't do that. But I saw human services at the last minute and actually switched on the first day of my first class. Human services is just such a broad field that encompasses so many things we don't think about. Law enforcement, EMS, homeless shelter volunteers, crisis intervention workers, parole officers, domestic violence workers. All of those are human services workers and under the very broad field. So part of my work with human services is bringing awareness and recognition to my specific specialization, which is crisis intervention. And then under that, of course, there's different fields, right? So I personally work with emergency services. I don't typically work with the general public because I'm able to relate and build that empathy with other emergency services workers, which is a big thing with post-traumatic stress disorder, is the ability to relate and build that empathy. So responsibilities with my crisis intervention work, I co-founded and am now the president and coordinator for the local critical incident stress management team I talked about. So anytime that an emergency services worker in our county or surrounding areas would need some type of intervention, I would be the one they call, and then I set that up. I'm not always the one that goes. For example, I don't have any fire experience. So if a firefighter calls and, maybe they had a fire fatality in a house, I would not go on that if I had a firefighter on my team that was able to respond. Because again, as a peer-led program, they're able to relate better to that than I am because I've never ran into a burning building trying to save someone. So that's the responsibility there. Some other similar peer work, but not necessarily that I do. I mentioned that I founded a suicide prevention coalition last year. We are working to build a support group as a kind of subgroup of that coalition. But the coalition works to prevent and bring awareness to suicides in the county. As with much of the United States, the county that I live in, 2022, we had a record number of suicides, tied only with 2 other years since 1990. And in the United States, 2022 was the highest year on record for suicidality as well, unfortunately. But as a death investigator, I'm able to see that directly firsthand in our local county. So that's what brought me to found the Suicide Prevention Coalition. And we just do whatever we can to bring awareness. So somewhat peer-led. I think those would be, did that answer your question about my responsibility?
Yeah, absolutely. Yeah, I'm curious what is so crucial about the work that you do. I know we had previously discussed kind of how broad crisis intervention is, but how kind of empty the established theories and application. So, if I was just someone kind of off the street and I never met you before, and I asked you what is so important about what you're doing, what kind of would be your answer?
Sure. So I'll try to break that into a 2-part question and remember both parts. Specifically working with emergency services, the importance is we outrank the general public in numbers in a very bad way. Emergency services workers are 60 to 75% likely to get a divorce in their marriage, as the general public has held pretty steady at 50% divorce rate. So that's 3 out of 4 police officers, firefighters, 911 dispatchers, EMS clinicians. 3 out of 4 of them are likely to get a divorce. Part of that is because we, and I say we as emergency services personnel, we go home. We've had horrible shifts. We've seen things that humans aren't meant to see. We then we go call to call. We can see a terrible thing. Then we maybe make a traffic stop. Then we go on an ambulance call of somebody that stubbed their toe and called 911. But then we go back to another horrible traumatic call. It just kind of ebbs and flows throughout the day. Then that builds up and we don't talk about it, right? Because of the stigma, and this is quote unquote what we signed up for, and just all of the stigmatization surrounding mental health challenges with emergency services. Then we go home and we don't talk to our significant others for whatever reason, whether it's we think we can't, even though almost every state, if not every state, has laws protecting confidentiality between spouses. That's privileged communication. Or we don't want to because we don't think that our significant others can handle it. We don't want to talk about it. We've dealt with it all day. We just want to sit. But when you get home, right, your significant other, your kids, they want to play, they want to talk, they want to be with you because you've been gone for 8 to 12 hours. So on that note, I emphasize the importance of talking to your significant others today while things are good about, when I come home this way, here's how we can kind of support each other. Here's the things I can tell you. Here's the things I won't tell you. And then just continuing with the statistics, we have a 30, as of 2018, I think it's probably more of a 30 to 35% now, substance abuse rate in emergency services. The general public has 20 to 25%. So we outrank by 5 to 20% there in a non-good way, right? Again, because that's our maladaptive coping skills to try to process and cope with the things we experience throughout the day. We get home, we want to relax, so we have a drink or we use a substance to help our body relax, right? But those types of things impede your brain's ability to process and return to normal adaptive functioning from that traumatic event. Your brain has to process that trauma, and maladaptive substances like that impede your ability's brain to do so. And then I don't have any data to support this, but from personal experience, I know that increased substance use then leads to increased OWIs, right? In the personnel that are responding to those accidents, making those arrests, then we're in an impaired state and we're doing those very things. Okay? And then just the stigmatization. It's referenced in hundreds of articles, and I can say that with certainty because I reviewed hundreds of articles for my dissertation. The stigmatization is still very apparent. While I said I think it's getting better, it's just the stigmatization from the bottom up and the top down. When you have chiefs and lieutenants and captains who don't promote that mental well-being and that intervention, it's going to be really hard for those subordinates, for those boots on the ground people, if you will. And then the other way around, the boots on the ground people, if they're not internally promoting that wellness and feeling that it's okay to go seek that help, it's not going to spread up and out across the other personnel. In a broad sense of the work that I do and kind of bringing the awareness, crisis intervention is just not a recognized field. And I mean that in a sense that it's being recognized in the United States because the public is demanding it, but I don't think the public necessarily knows what they're demanding, and they just want a solution to that. And what I mean by that is law enforcement liaisons or crisis-trained police officers have exploded in the last 5 years in the United States, really. And that's because so many law enforcement encounters are mental health related, and what the public was seeing from those interactions, how they felt law enforcement officers were handling them, were negative, and they were getting a very negative perception of those. So in response to that, they now have mental health liaisons or crisis-trained police officers that have some type of training, usually in crisis intervention, although sometimes they don't. Sometimes those people may be, bachelor's level trained human services clinicians or human services practitioners, or maybe they don't have a bachelor's degree. The requirements vary so much from no college at all to a college degree and 40-hour crisis intervention training. But then you go, these practitioners that are doing this crisis intervention work in the field will go maybe get assist training, which is a 16-hour suicide intervention training. Or they might get psychological first aid, which is a 4 to 8 hour course, depending on how you do it, which was developed more for disaster situations, not on the street intervention. Or, any number of crisis intervention, suicide intervention awareness, or, trauma awareness trainings, and then they're going to do this crisis intervention work. But just as with anything else, I think I used emergency medical services in our conversation before. Just like anything else, there's theories, there's methods, there's tactics that go into crisis intervention, and getting a 16-hour assist training certainly does not qualify you to go provide, it shouldn't qualify you to go provide crisis intervention on the street every day as a profession. So just, again, I'll relate to emergency medical services. If you think about the order in which that goes, you have emergency medical responders, right? Very basic level, shortest course. It's the least invasive of any, they can do the least invasive interventions, right? They are, quote unquote, the first people on the scene typically. Okay? Then you have emergency medical technicians. They can do a little bit more invasive things. They have a broader scope. Then you have advanced emergency medical technicians. Their scope again broadens. And then you have paramedics who can do the most invasive things. They have the broadest scope. As you learn more theories, methods, interventions, all the way up to paramedic, which a lot of places now are requiring an associate's degree, because you have to learn anatomy and physiology. You have to learn some theory behind paramedicine. You have to learn why we're doing some of these interventions, not just how to do them. So same with crisis intervention. We have such a broad scope, as we've talked about, from licensed psychiatrists, right? Medical doctors that fall under this field. And then we have, staying on the field of mental health under human services, then we have street worker crisis interventionists who may have no college at all, providing mental health intervention to people, right? Those crisis intervention workers, they can't just learn one theory and one method and be prepared to go handle every situation they're going to come into contact with.
Would you say that there's a stronger need for all the different types of roles that fall under crisis intervention, from those working on the streets directly to, emergency service providers, for there to be like this collaboration and developing what crisis intervention looks like broadly, but also specifically?
Yes. I definitely think there could be a broader program to provide um, education to the crisis intervention field, right? And that could cover some broad theories and methods. And what I mean by that is, you know, casework management, for example. We could see somebody multiple times and have to do casework management. A lot of the time, that term falls under social work. So then you need to know some social work theory, right? Then we could be diving more into a mental health aspect, and maybe that falls under psychology theory. Then we need to know sometimes what is causing someone to be in a crisis. Maybe that's your person and environment theory, or maybe your ecological systems theory, right? So I don't think, I certainly don't think that every crisis intervention worker needs to have a master's degree or a PhD, because that certainly wouldn't even be possible, right? But they do need to have an awareness of at least a little bit of these theories, starting at the associate's level, just like as we do with other programs, starting at the basic, maybe 40-hour course or associate's degree. I think we need to find a way to build up these programs, just as we have with other recognized professions. And as I said, the public has demanded this. They just, I don't think, necessarily always know what they're demanding. They just wanted a solution to law enforcement interaction, right? And that's a lot of where crisis intervention has stemmed from. But if you think about all the other aspects, the same methods, the same theories. For example, one of the programs I use is critical incident stress management that I mentioned from the International Critical Incident Stress Foundation. Well, that theory, that method wouldn't necessarily be the best approach to working with a caretaker who's maybe experiencing cumulative stress and burnout, or a survivor of sexual assault or domestic violence, right? Maybe Robert's 7-step model would be a better approach, or any other number of methods that we have, and intervention models that we have might be a better approach to them. But if you only know one method, you're only going to use it. If a hammer is the only tool you have, you're going to use the hammer.
No, that definitely makes sense. You have a great recall of your systems and models. I'm over here thinking like, oh yeah, I remember breaking that down. With the work that you're doing specifically, what kind of impacts have you seen to your community as a whole?
Oh, I should have pulled up these numbers if I knew.
Well, from your experience as the lead,
Yeah, I just calculated this for our county at the beginning of the year. So since 2020, when we became officially a 501c3, we have done I don't remember, somewhere around 50 hours of intervention or something, helping. I think it was well over 100 emergency services workers, and 30 some agencies, maybe. Those are guesses, because I can't remember the numbers. But it showed, because sometimes we'll go months where we don't necessarily have an intervention, right? And then we might go a week where we have 2 traumatic events and provide intervention to 50 emergency services workers. So it was nice to see sometimes on a day-to-day, when you don't necessarily feel like you're making that impact on a team. It was nice to add all those up and be like, that is, 100 emergency services workers that potentially would have had no intervention if our team had not been here. Because a lot of the time they're only going to reach out once, right? And I know that from experience. If I call and you don't answer, or you pawn me off to somebody else, or you can't help me, I might not call anybody else, because I just don't have the energy or motivation to do it.
Yeah, that's definitely relatable, because you have to work up that energy, right? That confidence to just say, I'm going to do it. And that's exhausting in and of itself, for sure. Going forward, what do you imagine the crisis intervention field becomes, either on a broad scope or specifically with the work that you provide?
Sure.
I guess what is your biggest hope? I guess your dream scenario,
Sure.
or the realistic one.
Sure. Well, I hope that my dream scenario is real someday. but I would like to see, currently, to my knowledge, and this of course could be wrong, there is not a specific program that is recognized for crisis intervention for states or nationally. There are different programs, and I won't name specific organizations, but there are specific programs, some of which are a 4-hour course, some are, like I said, a 40-hour course. Some are, one is a certification that you read a bunch of books and then take some very poorly written tests, and that's your certification. I don't like any of the programs that are out there as a specific program. So I would love to see something built that covers crisis intervention in a very broad field, but is still applicable to potentially the person who doesn't have any college degree and is doing that work every day as a profession. That person needs to be recognized too. And again, in my dream scenario, we would start to recognize crisis intervention as a field, or crisisology as a field, just as we do with, ology, the study of something, the study of crisis. And the intervention part, and why I specify that is when people think of crisis, sometimes a lot of the time they think of crisis at like a business, like you have a Fortune 500 company who has a cyber attack and they call in someone to manage that crisis for them. Two very different areas of crisis, right? Than being on the street and intervening with someone who is experiencing a mental health challenge and having a crisis. So it would be great to see that recognized from a certification aspect and even a licensure aspect in the States, where they're making you, it's a test you have to take, just like a social worker, a psychologist, or a mental health counselor. It's a license, it's a certification, and then you have to do, 8 hours of continuing education a year or whatever that amount is. But currently, like I said, state to state, there is not necessarily a recognition or awareness aspect of that, to my knowledge. And a lot of states are coming out with like peer support certifications. And peer support and traumatic stress and crisis intervention are similar, and sometimes they overlap, but sometimes they're very different, right? You can look at being relatable on a very broad scale. For example, I can be relatable to all emergency services personnel because I've been there. I'm not relatable specifically to firefighters because I haven't done that. So where someone who maybe has lived experience is working on the street as a crisis interventionist, that person may have lived experience with depression, but they have to be able to go intervene with someone who's experiencing schizophrenia, who has psychosis, who has bipolar disorder. So you can be relatable on a broad sense, but then once you narrow that down, you may not be relatable. And you still have to know how to intervene with that person. And sometimes it's very basic. Maybe you're only, the first step in any intervention model should be meeting basic needs. Because if we're not meeting basic needs, safety, water, food, warmth, shelter, you're not going to make any progress with that person. But then from there, models can vary. While they have similarities, like proximity, immediacy, and expectancy, the way that we accomplish those goals, the flow, the guidelines that we use will differ model to model.
I perceive it as like this back and forth system of, those who are working in the field, who build that experience, who are developing this application based on what their needs are while in practice of crisis intervention, kind of feeding into how crisis intervention in and of itself does develop. Because like you had said, like, there is a scenario where there is a greater emphasis on structuring how this education and experience level is distributed, but then it does get pretty specific. And that is the challenge that we see in this field, is that we are so broad and there is so much need and dependency on other like subparts of our field. But also you wouldn't necessarily send a social worker to a crisis intervention scenario. And I can only imagine in my head how fast-paced crisis intervention, occurs, because you basic needs first, right? And then let's say you have someone on the scene who doesn't have much experience with somebody who is bipolar or has schizophrenia. Then you have to turn around and get that expert, there on the scene. And so constant. But I have a lot of, I don't want to say hope, as in there's hopelessness in the crisis intervention development, but you do see that in other aspects of, basic care provision. Technically, theoretically, the system is set up where you go to the hospital, right? In the medical field, and you have a specialist on site. And if that person can't do what they're, supposed to do or what you need, they can immediately come and bring somebody in who does know what you need. So it might not be as quick as a scenario or process, but the fact that it already is consistent in a way that plays out to support, providing someone their basic needs, it makes it more realistic and probable that not necessarily the exact process, but the way that it can be built and structured and applied and executed is incredibly doable. And so I think your dream scenario is very close to a picture of reality. I wanted to know if you were to meet somebody or have any advice for someone who's either interested in crisis intervention or maybe is already working to some degree as a crisis interventionist, what would be the biggest advice that you would give them?
Sure. Do you mind if I answer a couple questions that you brought up in my mind with what you just said?
Absolutely. Yes, please.
I forgot more than I'm going to answer because that was good. But so if we think about just relating this again to paramedicine, just because I have the experience, some of these things are going to be like what we call high risk, low rate use. So if you think about, for example, surgical crikes, right? Where you cut a hole in somebody's throat and put a tube in. In paramedicine, we rarely do that in the field, right? Rarely. We still have to know how to do it though, right? So that's one of those things you're not going to train on every day or at every meeting, but you still at some point have to train on it to keep your skills right. That's where kind of this having the awareness of these models and theories isn't something that you're going to know every day, right? Like if you work in a county, you're going to have probably a good knowledge base of what you are most likely to encounter in a crisis, right? But you never know in these fields, just like you never know what call you're going to go on as an EMS clinician. So you still have to have the awareness and the background. The other thing, I'm really glad you said that you wouldn't send necessarily a social worker to a crisis intervention response, because that's what's happening. And I support that wholeheartedly. If that licensed clinician has crisis intervention experience. But what is happening in this field and where it lacks awareness and recognition, I'm really glad you said that, is we as the general population in the United States are assuming that mental health clinicians who are licensed, so that's your social workers, your psychiatrists, your psychologists, your mental health counselors, we're just assuming that they have crisis intervention experience. And I know for a fact that that's not true because I've had licensed clinicians tell me my crisis intervention training in school to be a clinician was call 911. Well, guess what? 911 doesn't always have the resources to deal with that either, which is why then the police and emergency medical services get sent, depending on their level of training. Why we've embedded crisis intervention with these professions is because we were going to jail or we were going to the hospital, right? And so that was not an appropriate place for someone who doesn't necessarily need to be in a hospital and didn't commit a crime. Right. So that's where these crisis intervention workers, one of the biggest, most important things they have to know is what resources are available to them in their area of operations. If I was going to talk to someone who was new in the field, I would tell them to get ready to be an advocate for themselves and the profession first, because this has to grow. We have to recognize this profession. Just as we do other mental health professions. I would tell them to take all the trainings they can, right? All of the trainings that we talked about: assist, psychological first aid, critical incident stress management courses, crisis intervention courses, traumatic stress courses, because they're all helpful. I guess I would find a way to lay out for them where they want it to be. So, do they want to progress and advance the profession? Then I would tell them to start on degree tracks. They have associate programs in human services. You can specialize in crisis intervention. They have bachelor's, master's, and obviously doctoral programs. So it would just depend on what that person wanted to do. Then I would, if they're interested in working with a specific population, for example, emergency services, they need to submerge themselves in that culture. Just because you have a passion for emergency services, or maybe you have a passion for survivors of sexual assault, or whatever the specific profession is, if they want to work with one, they need to immerse themselves in those cultures, because the things that emergency services workers are going to tell you, you can't just handle that off the street with no prior warning, because they're going to scare you, they're going to make you cry, they're going to make you sad, because they're very traumatic sometimes. And what often happens is when emergency service workers will go see clinicians who have no cultural competence in emergency services work, I've heard stories of where they've made them cry with what they've said, and that's not okay, right? The clinician is supposed to be there to help and support their client, and it doesn't matter what the client is telling them. So, if you're asking me about emergency services, you need to go on ride-alongs. You need to read books, read articles, go talk to your police department, your fire department, your EMS agency. If you don't have the experience of being in the fields and you are coming at it from a clinician perspective, you have to immerse yourself in any culture that it is that you want to work.
Tell me, before we hop off, about your professional development webinar that you have in July coming up.
Yeah, so hopefully I get the date right since we're on camera, but I think it's July 30th that I have a professional development webinar for National Organization of Human Services. And it is called Crisis Intervention Concepts to Practice. I'm going to do an hour of kind of what we just talked about, but more specific. What are some theories? What are some methods? And then, what do we expect as an entry-level crisis intervention worker? And then to the providers that have been doing this for a long time, are we thinking about immersing ourselves in the culture? Are we thinking about different theories, different models of crisis intervention? Or are we trained in one model or method, and that's what we've been using? So I'm hoping to just really bring awareness to the field as a whole in the hour that I have. New people in the field are thinking about it from the start, and people that have maybe been in the field for a long time are hopefully thinking about something new they might be able to learn and how they can help advance the field with me.
Awesome. I'm so excited for this. This is going to be great. I know you only have an hour, but you're great at delivering the information that you have, especially through your experience. So thank you so much for coming on.
Thank you. I really appreciate the opportunity.
Special thanks to our guest, Dr. Braxton Morrison. Be sure to register for Braxton's professional development webinar on July 30th for an in-depth exploration of crisis intervention in the field of human services. Are you or someone you know interested in joining us at the roundtable? Let's talk about it. Connect with the team at info@nationalhumanservices.org. You can find all our roundtable conversations on YouTube, Spotify, Apple Podcasts, and the iHeart Radio app. Be sure to follow us on social media and check out our website for everything NOHS.